Hello, everyone. Today we will review the management of chronic coronary disease using a practical guideline based approach. Our focus will be on how to assess risk, how to choose the right medical therapy, and when revascularization actually helps. The key theme throughout this talk is individualized care. In chronic coronary disease, good management is not about automatically following a rigid algorithm, it is about matching the right strategy to the right patient. The goals of treatment chronic coronary disease are straightforward. First, we wish to prolong survival. Second, we want to improve quality of life, especially by reducing angina and improving effort tolerance. Third, we want to reduce cardiac death and non fatal ischemic events such as myocardial infarction. To do all of that well, we must begin with accurate risk assessment. Before choosing therapy, we need to understand who is low risk, who is high risk, and who may benefit from more aggressive intervention. The first step is recognizing the syndrome. In the classic patient with chronic coronary disease, the symptom pattern is stable angina. This is temporary chest discomfort triggered by predictable exertion or emotional stress and relieved by rest. That is a pattern that tells us there's a supply demand mismatch. The myocardium is briefly unable to get enough oxygen during stress, but symptoms resolve when demand falls. At this stage, our job is to act like clinical detectives. We need to decide whether the presentation fits stable ischemia and whether there are high risk features that require further workup. Once CAD is suspected, we need to move to risk stratification. The key non invasive tool is exercise testing. Typically, treadmill exercise using a Bruce protocol is done, but the value is not simply whether the patient can complete the test. We look at three major components: exercise capacity, ST segment changes on EKG, and angina symptoms during exercise. These findings can be combined into the Duke treadmill score, which helps classify patients into low, intermediate, or high risk. This risk estimate then helps guide how aggressive we need to be with treatment and whether revascularization should even be considered. For those who cannot ambulate on the treadmill, we do pharmacological testing. After risk stratification, management can be organized into three major pillars. The first is lifestyle modification, the second is optimal medical therapy, the third is revascularization when appropriate. This structure is useful because it reminds us that procedural therapy is only one part of management. In many patients, the most meaningful gains in symptoms and long term outcomes come from risk factor control and excellent medical management rather than immediate intervention. Lifestyle therapy is the foundation of treatment. Patients should be encouraged to follow a Mediterranean style diet, which has been associated with improved cardiovascular outcomes. We also recommend at least 150 minutes of moderate aerobic exercise per week, assuming there is no contraindication. Smoking cessation is essential and remains one of the most impactful interventions we can offer. An important clinical pearl is to avoid overpromising supplements. Vitamin C, vitamin D, omega 3 supplements have not shown clear cardiovascular benefit in this setting, and vitamin E has even been shown to be harmful. So, lifestyle advice should focus on proven interventions, not nutritional shortcuts. The second pillar is optimal medical therapy, and in many ways, it is the most important. Historically, clinicians were taught a stepwise drug ladder, often beginning with beta blockers and adding therapies in sequence. But More recent evidence has shown that this rigid approach is too simplistic. There is no single universally best first line anti anginal drug for every patient. Instead, the modern approach is tailored therapy. We choose medications based upon the patient's heart rate, blood pressure, symptom pattern, and comorbidities. For example, in somebody with asthma, a beta blocker would not be a first line drug. This is where clinical judgment matters. If a patient has angina along with hypertension and tachycardia, a beta blocker can be an excellent choice because it lowers both heart rate and myocardial oxygen demand. But that same drug may be a poor choice in a patient with bradycardia, conduction system disease, or reactive airway disease. In those patients, a calcium channel blocker or ranolazine may be safer and more effective. The important lesson is that therapy should be reflective of the physiology in front of you. We should not prescribe reflexively. We should prescribe thoughtfully, keeping the patient and comorbidities in mind. Optimal medical therapy is not just about reducing chest pain, it is also about preventing future cardiovascular events. High intensity statin therapy is essential with the goal of reducing LDL by more than 50%. In very high risk patients, aiming for an LDL below 55 is appropriate. In patients with diabetes, neotherapies such as SGLT2 inhibitors and GLP-1 receptor agonists are especially important because they do more than improve glycemic control. They also improve cardiovascular outcomes. So when we say medical therapy, we mean comprehensive vascular protection, not just symptom control. After LDL has been controlled, there is still residual risk that remains, which can be addressed by using icosapentol ethyl and other similar medications. Now we come to the third pillar, revascularization. Landmark trials such as Courage and Ischemia change the way we think about stable coronary disease. These studies have shown that in patients with stable coronary disease, starting with an invasive strategy such as PCI does not reduce major cardiovascular events better than starting with optimized medical therapy. That is a critical teaching point. For stable chronic coronary disease, stenting is not automatically superior to excellent medical care. Revascularization should therefore be used selectively and intentionally, not reflexively. We should not have the oculostenotic reflex, where the minute you see a lesion, you go ahead and fix it. So, when should we revascularize? There are two major groups. The first includes patients with high risk findings based on testing or anatomy. The second includes patients whose quality of life remains poor because of angina despite well executed medical therapy. In other words, we should intervene when there is prognostic benefit or when symptoms remain. These symptoms should be unacceptable despite our best conservative efforts. This helps frame revascularization as a tool for specific clinical problems rather than a routine default. Additionally, it is best to use clinical scales such as a scale for angina to assess whether symptoms are worsening, not just put down that angina has worsened. Now, whenever patients undergo revascularization, either with a stent or bypass surgery, we have to balance ischemic versus bleeding risks. In patients who do not have stents or coronary disease, we use aspirin or aspirin along with Xarelto 2.5p or BID if patients meet criteria for the COMPASS trial, which include diabetes and CAD, diabetes and CAD and peripheral vascular disease, CAD and cerebrovascular disease. Patients who undergo PCI or stable CAD should continue DAPT for at least 6 months. Those who undergo PCI for acute coronary syndrome, DAP for at least a year. Post-CABG, aspirin should be continued indefinitely, and a lot of surgeons are currently preferring Plavix use for at least 3 months. For perioperative non-cardiac surgery, Plavix should be discontinued 5 days prior to surgery, Tricalagor 3 days prior, Prasugrel 7 days prior. Aspirin should be continued through the surgery. Now, we also should strongly consider de-escalation. If patients have AFib along with CAD, triple therapy, namely DAPT along with um, stroke prevention, such as a NOAC, should be for 1 month, followed by dropping the aspirin and continuing the NOAC along with the Plavix. For patients on DAPT, early de-escalation, 1 to 3 months, where you drop the aspirin, should be strongly considered. PPI should be used for GI protection. There are certain high-risk ischemic patients in whom we have to consider continuing DAPT longer, if not lifelong. For example, left main stent, bifurcation stent, stent placed in the setting of acute coronary syndrome, stent length more than 5 centimeters, prior stent thrombosis. When revascularization is needed, the next question is whether to use PCI or CABG. This decision should ideally involve a heart team approach, especially in patients' with complex anatomy. The syntax score helps quantify anatomic complexity. In patients with simpler coronary disease, PCI and CABG may have similar outcomes, but in patients with complex multivessel disease, especially those with diabetes, bypass surgery is often the better option. The FREEDOM trial made this especially clear. In patients with diabetes and multivessel coronary disease, cabbage is superior to PCI for reducing death and myocardial infarction over the long term. Let me end with the major take-home points. First, in stable chronic coronary disease, optimal medical therapy is the cornerstone and is often just as effective as initial stenting for preventing major cardiovascular events. Second, antiangiogenic therapy should be tailored to the patient's heart rate, blood pressure, and comorbidities, not prescribed as a rigid ladder. Third, diabetes strongly influences revascularization decisions, and in multivessel disease, cabbage is often superior option in these patients. Fourth, bleeding risk is central when deciding DAPT duration after PCI. And finally, the most important principle of all, treat the patient, not just the angiogram.